Welcome to the last session of our conference. It's been a great conference so far. My name is Carl Hein. I'm on the Washington ASEP board and also on the planning committee for the conference. And it's my pleasure to be the moderator for this final session on basically what is central nervous system emergencies. The first one I'd like to introduce is Dr. Rod Askewian. Dr. Askewian is a neurosurgeon over at Swedish Hospital. He did his undergraduate here at the University of Washington, then went down to UCLA for medical school, and then went over to the University of Virginia for a neurosurgery residency. And I have a bit of a story to tell about that. It's a short story. A good friend of mine was a beginning emergency medicine resident, and he was on the trauma service. And somehow he got enough time free to sneak off to the call room on his trauma rotation. And at that time, the call rooms had bunk beds so you could stack residents taller for the small space. And somehow, I don't know quite how, he fell out of the top bunk. And being a good ER doc, he wanted to keep finishing his shift and then go home and just sleep it off. But Dr. Askewian was his colleague there and recognized that he just wasn't quite right. And so insisted on wheeling him down to the emergency department for an evaluation where it was discovered he had an epidural hematoma. Went to the OR, got it evacuated, eventually had a good recovery, finished his residency, and is now a practicing emergency physician. So in addition to all the other accomplishments and awards that Dr. Askewian has amassed that are on his CV, he has another distinction, and that is having helped save the life of an emergency medicine physician. So we're thankful for that. After his residency, Dr. Askewian went to do a fellowship down in New Zealand, and now, like I said, is on the staff as an attending neurosurgery physician at the Swedish Medical Center. So.
Thanks, Carl, for the introduction. It's funny because I'm actually flying out to Virginia tonight, and I've seen a few people here from Virginia, so it's good to see these guys. And Steve Huff is here as well from University of Virginia. So I'm going to talk to you today about kind of an area that's, that I'm very much interested in, that's spine trauma. And we'll kind of try to go through, I've got over 100 slides, but being a surgeon, you know, I'll probably spend about 1 second per slide. So we'll just kind of go through this pretty quickly. So spinal cord injury, as you guys know, and spine in general, it's probably one of the #1 things that people go to the ER for. And spinal trauma is something that you guys will all see, and it's fairly common. Basically 2 groups. You've got the young people and the older people. And as you guys know, the prevalence is pretty significant. And this is an interesting slide because, you know, most of the time with spine injuries, it's never going to be this obvious. You know, this is obviously something that, you know, even a med student can figure out that there's something wrong with that x-ray. So when do you see it? MVAs, falls, sports injuries. In Seattle, occasionally you'll see a gunshot wound, not as much as I did back east, and in some of the larger cities. And if you break it down, most of the injuries are going to be in your cervical spine, and followed by the thoracic and lumbar spine. This is a patient who had a gunshot wound, and again, you know, some of these, it's never going to be this simple in terms of diagnosing someone, and the economics, especially nowadays, is significant, and some of you guys know this already, but this is like 10 years old. I'm sure it's much higher nowadays. You know, having somebody in the hospital for a month and then having long-term care is going to cost more than $1 million, which is essentially what they sort of averaged up. And a lot of the injuries are related to work, labor and industries. Each state has sort of an L&I type situation, and it's a significant cost. You know, this is old information, so I'm sure that's ballooned up as with time. And some of the things, you know, with ER stuff, which I think is important, is, you know, what do you guys see and what's important? And really the significant advances in ER patients now in the last 20, 30 years, I think, is the pre-hospital management. The EMS folks, the doctors that are on the scene, people get immobilized immediately. And you can see that this has had probably the most significant impact is the pre-hospital stuff that goes on rather than what we do in the hospital. Most people, obviously with MVAs, are going to have head trauma, chest trauma, abdominal trauma. If they've been in a trauma, you can pretty much, there's a good 10% chance that they're going to have some sort of spine fracture or cervical spine fracture, so it's almost diagnostic. And obviously you want to follow the protocols and treat these patients as you would and stabilize them. So one of the things people always ask is, what can you do in terms of in the emergency room? Is you can do certainly a lot. You can try to realign these people if they've had a subluxation or they've got a dislocation. And one of the things which you see a lot in cervical spine injury, for example, is people the airway and their difficult airways. And I've seen during residency and even now as a junior sort of attending, I've seen patients with bad cervical spine injuries that are difficult to intubate. And I just, my one advice to you guys, especially if you're out, you're kind of on your own, is you can bag these patients for hours until you get help. So I've been in that situation. In fact, when I was in New Zealand, is that, don't panic, just kind of relax. You can always bag somebody. And once you start trying to intubate these people and you aren't going to do it and you're by yourself, then you can get yourself into trouble. And of course, these people, especially cervical spine injuries, are going to have some cardiac issues and blood pressure issues, which you guys are familiar with. Most of these patients, you'd want to have a Foley catheter in, put an NG tube in, all the stuff that you normally would do for any sort of trauma, even if they're awake. One of the things that's come out recently is we use the Asia scale to identify the level of the injuries, and this has sort of become synonymous now. Before there was 18 different ways to classify. And for me, always, it's not so much, well, are they 3 out of 5, 4 out of 5? Is the guy wiggling his toe? Really, is the patient complete or an incomplete? That's really the key from a neurosurgical standpoint. Does the patient have any sensation below the level of fracture? And that's really the important thing. That's what I want to know. And I think that's what's important for you guys, because if somebody's incomplete, that means they still have fibers that are functioning. And those people tend to do better than obviously the complete ones. And again, I just sort of included actually in the, I think the USB drive you guys got. This is the scale, and you can spend a lot of time talking about it, but really the take-home message for me, if you're emergency room physician, you see somebody with a spinal cord injury, that's the key. Do they have a complete injury or an incomplete injury? And that's the best way to go all the time. You can never go wrong. And they've sort of tried to, this is the grading scale they use for Asia. You guys can take a look at this. And then the nice thing about the Asia scale is that they've actually broken it down so okay, well, C5 is deltoid. L4 is tibialis anterior. So they've broken it down so you guys, when you're in the ED, you just check the box and go on. Obviously these people, a lot of times get plain x-rays, and you do the standard trauma series, in plain x-rays you can actually diagnose quite a bit, but you can also miss quite a bit. So obviously if it's a trauma, you're going to want to get more than just a plain x-ray. And unfortunately, even let's say 10 years ago, this is kind of what we were doing. I remember doing this as an intern. But, everybody's different. X-rays are terrible. Even to this day, I sort of get bad feelings when I see these lines because I think of boards. So even, you can see here, it just keeps going and going. So it's absolutely useless for me now because you've got 64 slice CT scanners almost in every emergency department. So you could sit there and try to do all these lines, but you know that there's some pathology there, just even on a regular CT there. So the addition of spiral CT imaging, my advice to everybody is just get a CT scan. It's cheap, it's fast, you're going to catch more than 90% of all these injuries, and you're never going to regret getting a CT scan in somebody. And actually the story Carl told, that's a great story, but if he wouldn't have got a CT scan and gone in the ER, it took 5 seconds to do. And that's just kind of, I've never ever regretted getting a CT scan on somebody. And most ERs, even if you don't have an MRI, that's what I recommend you do. And make sure that it goes past C7 and includes T2. So here's an example of a plain X-ray. And if you just sort of look at it, well, you say, well, geez, that looks pretty good. But if you get a CT scan, you can see that there's something wrong here. This patient has a severely unstable 3-column fracture. So, this would have probably been missed on just a plain X-ray because it's often hard to tell down low. And again, MRI is helpful because it can tell you in terms of prognostic, if somebody's got a hematoma in their cervical spine, well, that patient is going to do poorly no matter what. Or if they've just got a contusion, central cord type syndrome, they'll probably get better on their own. So here's a patient who, unfortunately I don't have the axial images, but this is a patient who had a central cord type picture with a little bit of blood in it. And here's his plain X-ray, obviously, and he had real minimal symptoms for somebody who you would think basically would sort of be like a incomplete type person. And this is the image we got. And then obviously you get MRIs on almost everybody, especially high impact motor vehicle accident type situations where you'll be able to assess the ligaments, and you can basically, throughout the entire spine, but it's extremely helpful in a craniocervical junction. You can look at the joints, the soft tissue, and ligaments as well as the spinal cord. So I'll just kind of briefly go through cervical fractures, which is very common. You guys will see a lot of these when you are working in the emergency department. You've got occipital condyle fractures, and again, this is, it's more boards type stuff, neurosurgery stuff, but I just wanted to throw it up so you guys can look at it. And there's classification systems for every cervical fracture you can think of. But again, I urge you guys to the other thing I think you should always do is consult with your local neurosurgeons and try not to handle a lot of this stuff yourself. And even with occipital condyle fractures, even with a CT scan, this is kind of a lower resolution CT scan. You can miss stuff. So doing an MRI, again, is very useful. And you can certainly miss a lot, and it's quite important. Obviously, they're not always going to be like this, where you're going to say, wow, that's an easy one. This patient is going to need something done. And for any occipital cervical trauma, almost always, if there's any evidence of, a lot of times these are very highly unstable injuries and need to be stabilized surgically. And then so we'll get to some of the other fractures. So atlas fractures typically are, you guys will see, you'll see it on CT scans. A lot of times they're not unstable, but again, it's important to do the workup and see. This patient had actually initially was sent out of the ED and then came back with significant deformity. Turned out that he actually had fractured the ring of C1 posteriorly, as well as ruptured the ligament that attaches the odontoid to the C1, which is the transverse ligament, and those are highly unstable. And these are, just kind of for you guys to look at. Obviously, you're not probably super interested in this. This is sort of a from an anatomy book, but it's helpful to see that really in this area the ligaments are just as important as the bones, and a lot of times you'll miss stuff, even on a CT scan. And the same rule for CT goes for MRI. I think you're never going to regret if there's somebody you suspect an injury on, just do an MRI. And you can rule it out. And again, these are highly unstable injuries and often need to be stabilized. Nowadays, the instrumentation has gotten so good that we hardly ever put people, make them non-operative. And again, there's many ways to treat this, these sort of injuries, especially atlas fractures that are unstable. Odontoid fractures is the most common thing that you guys are going to see. Fortunately, very rarely do people have a neurologic deficit associated with it. And again, they're all broken down. You can look at this at your leisure. The type 2 is what you guys are going to see in older folks. It's the most common, and this is approximately 50-75% of cervical fractures at C2. And the type 1 is just through the tip. Often these kind of heal on their own even if you don't do anything. But we put people in a collar. In New Zealand, we would regularly put people with C2 fractures in collars and follow up with them in clinic. In the old days, you would do a halo vest. And these are the most common and usually the most unstable. The C3 fracture involves going through the facet joints, and often those you need to manage with a collar. And again, these will heal on their own. The C2 fracture are the ones that typically don't heal. And the reasons for that is if they're older, they usually tear ligaments. If there's some risk factors, if there's more posterior displacement, and angulation. And again, I wouldn't, just call your neurosurgeon, whoever's on call. That's their responsibility. Don't try to, I've seen a lot of ER docs trying to basically help their colleagues, and in a lot of ways, sometimes it can backfire because they're not necessarily going to look at the scan and you won't know what you're looking for. So don't hesitate to call and get a consult even on these fractures that you think don't necessarily need to be seen. Here's somebody who had was sent out with just basically had a plain x-ray sent out, came back, occluded their vertebral artery, had a stroke and incomplete tetraplegia. Turned out that they had an unstable fracture. Obviously this is a lot more difficult to manage now than it was when they first came in. So again, I would, you're going to miss stuff on plain x-rays. This is somebody with a unstable C1 fracture as well as has a odontoid fracture, but these films were read as being normal. Of course, they were sent out. They came back in sort of a torticollis position. This is actually a sagittal CT scan. You can see how much far off the patient's neck is at this point. And again, this is much more, if you can treat some of these people with a collar or not, but obviously it's easier to try to diagnose that. And again, the ligaments are important. We always think about bones. I think I did as well, but ligaments are just as important in spine as they are, in fact, a lot of times more. And again, a lot of these fractures, you got to think about some of the anatomical aspects they can have. People can have occlusion, so they're at risk for getting stroke, especially if they're older. A lot of people have atherosclerosis. They don't have normal carotids, so they're only working on their posterior circulation. Even injuries that you think are stable that get sent out. This is somebody who was sent out with a collar, who had a quote-unquote stable hangman's fracture, came back. Again, this patient occluded their vert, had a brainstem stroke, basically a difficult situation to deal with after the fact. Hangman's fracture is usually at C2. It's kind of a hyperextension often seen in windshield-type strikes. And again, they can be unstable. They're usually not. And there's some factors associated with instability. Usually type 3 fractures or hangman's fractures, very rarely you need to operate on. This is very rarely do we do this anymore. Again, the instrumentation today has really, even if it's an older patient, there's significant risk associated with putting a 70-year-old in a halo and sending them to a nursing home. You know, I've seen pins go through the skull. People get epidural, subdural hematomas, infections. You know, there's just older people do not tolerate this, and neither do young people. So this is, you know, nowadays I think most people, they just don't hesitate to operate on these because the risks associated with putting people in halo vests. And again, for me, if you've got a complete lesion, there's things you look for, and this is the most important thing versus an incomplete, and the level of injury. So if you've got an incomplete syndrome, these are sort of, you know, we all know them from med school and residency, but I think it's good to know, well, which ones are going to do well and which ones aren't, and how do you kind of tease out which one is which. I'm just going to quickly go through this. This is a patient with central cord type picture, and we'll go through the spinal cord anatomy as well, just to sort of review it for you guys. So you've got your cortical spinal tracts, which are involved in motor, spinal thalamic tract, which are involved in sensation, in pain and temperature, and then you got your dorsal column, which is proprioception. So just keep this in mind when you're seeing people. And again, one of the more common things is central cord. Rather than the other ones, they're a little bit more obscure. You're going to see a lot of central cord, and this is exactly what happens. You have somebody who's got a disc, they've got some arthritis, buckling of different parts of the spine, and just even the smallest, you know, ground level fall, they can basically become quadriplegic. The presentation is always obviously greater weakness in the upper extremities, because that's where, you know, you've got an enlargement of axons in your cervical spine and your thoracic spine. And that's where all those neuron synapses from your motor cortex. So this is kind of I'm sure all of you have seen patients like this in the ER. And again, there's no, you know, one of my professors at UVA always said the patients don't always read the books. So obviously, you know, getting an MRI and sort of, you know, looking for if somebody's got a neurologic deficit, MRI all the time. So this is what happens in central cord syndrome. You sort of get the center of the spine and accordingly knock out the fibers for your arms first, and that's why the leg fibers are kept intact. And again, if you sort of look at, well, how are these people going to do? The natural history for this is that obviously if you're older, age is the best predictor of outcome. Patients who are over 70, who have got poor ASIA scores, do poorly even with surgeries. So similar to head injury, obviously the younger you are, the better off you're going to do. 100% of patients who have any sort of trouble with dexterity, walking, hands, that sort of stuff, almost all the time, these, even though they're incomplete, will have some trouble down the road. Brown-Séquard syndrome, you guys are familiar with. I'll just kind of briefly go through, is knocking out half your spinal cord. And this is a patient. This is that patient that we removed the gunshot on. They had a Brown-Séquard. So usually it's with penetrating trauma. Sometimes, very rarely seen in infections. Occasionally, you'll see it with a tumor. Very unlikely to see this with something like a fracture. And again, you go back to the anatomy. It's ipsilateral proprioception and dorsal column and paralysis, and then contralateral pain and temperature because of those tracts that we talked about. Again, this is an incomplete type of picture, so the patients are going to do better than they are if they have a complete injury. The worst prognosis for people in these syndromes is the ones with anterior cord syndrome, because normally this is basically you're having a stroke of your anterior cord. Obviously, those neurons are going to die. They're not going to come back. Very rarely seen. Occasionally it's seen. And again, it goes with the vascular supply, the anterior spinal artery. So imaging is key. And during my residency, I think I saw 2, so it's pretty rare, but you're going to see it. And again, MRI, brain, cervical spine, on patients like this. And unfortunately, the prognosis is very devastating. Even if they survive, the long-term outcome is very poor for these patients. This is a patient who had anterior cord syndrome when I was a resident in Virginia. And then, so cauda equina or conus medullaris syndrome, they're both sort of synonymous. You're going to see this as well, oftentimes seen with discs, can be seen as well with fractures, tumors, infections, and again, you're going to have bowel, bladder, lower extremity stuff because of all the neurons down at that level. This is a patient who had cauda equina syndrome from a fracture. And some of these situations, obviously, surgical stabilization is the way to go and can decrease the long-term morbidity and mortality with these patients. And then if you look at, it's funny, but if you try to kind of tease out what's going on in the literature and things like that, there's so much stuff that's gone on, a lot of retrospective studies. It's very hard to tell when people are going to do well and when they're not. But you can see here, this is patients with Brown-Séquard versus anterior cord central comb. Those patients do better because it's an incomplete lesion. In fact, that patient that had a gunshot wound that was removed is actually neurologically intact now. So those are incomplete lesions, and incomplete lesions, even if they still have sensory left, will oftentimes do a lot better than if you're complete. And again, studies after studies have shown this. There's always controversy about surgery, especially in the cervical spine. And again, that's why I just, call the person who's on call. Don't hesitate. Leave that decision up to them, because even amongst each other, we'll argue about who needs to be done and who doesn't. So it's not an easy situation. And actually, methylprednisolone steroids, do you start it, do you not start it? And this is a great paper. If you get a chance, please read it. There's no evidence whatsoever to show it. Even today, doctors will start it, afraid about lawsuits, whatever. That's fine. If I see a patient who's been transferred to me, who's been on it, I just let it run out. But this is one of the best papers you can read. And in the conclusions, it says basically that there's no proven, it says the use of methylprednisolone administration in the treatment of acute spinal injury is not proven as a standard care, nor can it be considered a recommended treatment. This is in 2000 that this paper came out. People are still giving it. I think the studies that were done, if you look at it, the results are sort of, on the fence. We just, I don't do methylpred, and I don't think it helps in the patient's eventual outcome. And again, there's guidelines that even newer ones have come out. There's no standards regarding the role and timing of surgery for any spinal cord injury unless it's something that, and most of this is because it's evidence-based. There's not a lot of prospective studies that have come out. And again, just because you've got this lesion doesn't necessarily need to have surgery. Always consult with your neurosurgeon, and we argue about this all the time. Late versus early. Obviously, if you've got if you're an incomplete and you've got a unstable fracture, this is a totally different situation. If there's intrinsic or extrinsic compression of the cord, again, these are reversible conditions, and obviously those patients do get better. And one of the reasons to do surgery earlier versus later is obviously you get stuff that goes on with the central nervous system, even with complete lesions that people advocate doing surgery versus doing it earlier versus later. You get reversible and irreversible changes to your central nervous system. And again, if you look at all the studies, you look at everything, basically age is the single best predictor of outcome. If you've got a poor neurologic condition, such as a complete injury, you're not going to do well. And if you do have, if you're under 50, you do have some sensory, even ability to walk or have bladder function, you're going to do much better. than that group, even if you do have surgery. And again, younger patients have much less trouble down the road. And you get, one of the reasons to do earlier surgery, which is a lot of surgeons now do versus later, is once people are stable, obviously, you can, down the road, get trouble with syringomyelia and neuropathic pain. I think is it's questionable. A lot of these people do have chronic pain issues. Even the ones you do early surgery on still get syringomyelia, still get cord tethering. So these are just sort of, there's no scientific basis for some of this stuff, but obviously we've had patients who do better and do worse, even with surgery. And again, for me, it's always incomplete, complete. Don't worry too much about whether it's, if the patient's got trying to get the perfect neurologic exam on somebody, especially if they've been in a trauma. They come in, they're strapped down to the board. It's kind of hard to get a real good exam. We were involved in a cervical spine trauma study. And again, these are difficult. There's a prospective study, and it's patients who had surgery versus not having surgery, and the ones that had surgery did better. But again, it's one study, and they were basically categorized, and they had unstable injuries of their cervical spine and dislocations and that sort of stuff. Those patients do better. One of the things I try to look for when I'm looking at x-rays, and when you guys look at x-rays, is that don't forget about the ligaments. There's a difference between let's say a compression fracture and something else such as a chance fracture, which also involves the bones and the spine. Just to review the anatomy for you guys, obviously everybody worries about the vertebral bodies and the spinal cord, but again, remember the spine you've got the anterior column and the posterior column, and we sort of divide it into 3 columns and classify things that way. It's made up of ligaments and bones, and I think in spine you often think, well, it's mostly bones and spinal cord, but the ligaments are just as important. Again, this is a pure ligamentous injury. There's no fracture. The patient ripped their interspinous ligament, their annulus. This is a highly unstable injury and needs to be treated operatively. Circumferentially, this is from the front. You can see that there's still this is not totally normal, and even MRI and CT scan confirm that preoperatively. These patients, these are highly unstable injuries. If you sent somebody home with that, plate would come out, and the patient probably sublux. And then I've got some questions in here for you guys just to review, and not to trick you guys or anything like that, but what I want to kind of nail home is that, there's a lot of debate about what you should do, and I always just say, call the person that's on call and let them decide, rather than trying to take care of it yourself. This is a nice biomechanical study that was done that basically shows that with shortening and compression and tension, there's going to be basically both bones and ligaments kind of follow this. It's a very well-known biomechanical principle that at some point stuff's going to give, and you get to a point where it's reversible up here, and then you get to a point where it's not reversible, and the same thing happens in bone. I'll just show you guys some x-rays here. So here's a compression fracture. This is, if you look at impact and bone displacement curve on somebody like this is probably somewhere along this line. This is something that's going to heal. It doesn't involve the ligaments. And then if you take somebody who's got maybe a little bit more of an impact, then obviously you're going to be higher up on this curve, and you're now starting to get close to something that's irreversible. And when you have a flexion distraction type situation, then there's a chance you're going to tear your ligament as well. And something like this, you're going to get way out here and then down here where it's not reversible. And again, it's very difficult to diagnose this if you get an x-ray like that and it's a trauma, you're highly suspicious, get a CT scan, get an MRI. You're never going to regret it. I know the insurance companies don't like to hear this, but it'll save you from having this patient come back to the ER and making multiple visits to different physicians. This is another patient who had down the compression and more force bone fracture. So now you get to the point where it's not only not reversible, but you get a burst component with this. And when there's that much, when you have a scan like that, you almost have to always be suspicious that you probably did something to ligaments. If you just look at the x-rays, it's real hard to tell whether that space is normal or not. They could be lying flat on the scanner. All these things play a factor. Getting an MRI on somebody like this is highly recommended. And again, this is going down the bone displacement curve. This is somebody with, who was sent out of the ER, and if you talk to the guy, he had this fracture a long time ago, but his ligaments were intact, and so that fracture sort of healed, and it looks funny, but the patient ends up doing fine. And it's real important to tell whether it's bone, ligament, or both. Can you just tell from an x-ray? No. Can you tell from a CT scan? You're going to miss it. This is somebody who had, you can tell there's absolutely nothing wrong with the anterior column. This is mostly, this is a highly unstable situation, and this is what we did, basically. And now the constructs have gotten so that, you can operate on these people. They're low profile. Basically, you can fix any fracture or injury, which is great. And this is the post-op x-rays. This is somebody who had fallen 4 weeks ago, was way off the bone displacement curve. And you can see here, not only did they rip their ligaments, but they've now got a thoracolumbar deformity as well as a neurologic deficit. And this was missed on the CT scan because the patient was flat. And there was no, nobody really thought about that, well, geez, it could be a ligament issue. Patient was sent out. So it's really important to make this distinction. And this is what happens is that in order for you to get a compression or a burst fracture, you have to sort of compress this area. And when you do that, obviously the posterior elements have to distract, and that's why you get the ligamentous injury. This is somebody who had an injury, and again, you're not going to be able to tell just from looking at the x-rays. An MRI was done. This is what it looked like intraoperatively. And again, you got to go back to the history. Is this patient in a motor vehicle accident? Was it a ground level fall? Did they get rear-ended? What's the deal? Again, more biomechanical studies, and basically that makes a huge difference. And I kind of sort of think about it. I can relate to it now because I've torn my Achilles recently. But if you pull silly putty slowly, it kind of deforms, okay, but it doesn't break. If you pull it real fast, it snaps. And that's exactly what happens with ligamentous injury in the spine. This is somebody with a high impact injury versus a lower impact injury. And the interesting thing is that you wonder, why is it always that when somebody's got a fracture, compression fracture, why the heck does it always look like this? Again, you go back to the engineering guys who have looked at this stuff. It's all based on biomechanics. This is basically kind of like I would say like a building, you're going to get the cortical bone has the most strength. This is all sort of trabecular bone, when you have a compression burst fracture, most of the weakest part of the spine is going to be there, so that's why you get it. That patient again had a cauda equina, again, you're going to be faced with all these questions, but I would just call neurosurgery. And oftentimes these people, when they're decompressed quickly enough, they do well. That patient had an incomplete injury and is actually neurologically intact now, had no motor function below, had no bowel and bladder, still having trouble with bowel and bladder, but actually has gotten motor function back. And this goes back to that previous slide that I showed you. This is what the spine looks like. This is why the stress concentration there, that's where you get the fracture. So when you get a compressive force, this is why the scans look the way they do. Obviously, not all of the patients are going to be like this, especially if you've got a fracture dislocation, which you're going to get different fracture patterns. But that's kind of the most common, and again, the biomechanics is the reason for it. This is a very nice illustration of why it's important to get a CT scan, MRI, and also to get a consult. This is somebody who had osteoporosis, was sent home because they were older. You know, they had a UTI. They couldn't tell whether the bladder stuff, what was going on. Was sent home, and within months, basically came back to the ER. Said, okay, well, now it's kind of, you know, borderline. Then we'll keep following it. Never saw a neurosurgeon, never saw a spine person. In the meanwhile, they've got progressive deformity. Their neurologic symptoms are getting worse. Finally, they come into the ER with an incomplete sort of cauda-equina syndrome, and this is what it looks like. Again, this is something, you know, back then you could do kyphoplasty. The patient goes home the next day. So I urge you to, you know, always, especially in older patients who have a lot of medical problems, don't hesitate to consult people. Don't hesitate to get neurosurgeon, orthopedic surgeon, whoever's on call involved. You'll never, ever regret getting a consult or x-rays. That's my take-home message today if I haven't said it enough already. And then this is what the scan looked like on the person. And again, this is a very difficult thing to treat now because basically this patient has osteoporosis, has a spinal cord injury, incomplete spinal cord injury, as well has a deformity. This is the patient that's flat, so that's why the x-ray looks so good. But the patient couldn't even get up to 10 degrees in the bed. And again, F is the answer for this one. Same here, E is the answer for this question. And I appreciate you guys having me out. This is a great conference and a great facility, and I appreciate the directors, and it's nice to meet all the emergency room doctors in Seattle, and it's good to be back in Washington.